Hello, good evening. Can you hear me? Hello, friends. Am I audible to you? When I say we're audible, we'll start. Okay, thank you. So we'll start. Look at this. We are focusing on target INICT. And this is a special session which is to help you crack difficult questions or slightly lengthy questions when it comes to clinical understanding. The problem with the previous session was that in NEET 2020, many students got clinically relevant questions. When the integration happened, some students were not able to find the link between the two different concepts. So because of it, some questions were appearing very lengthy. Whenever you have a lengthy question paper, the problem is that you will not be having enough time to finish it. So for that, we are running this particular session. Before we go into the topic, I have to do the mandatory promotions. So let me tell you this. This is Dr. Meenakshi Sundaram here, and I have an experience of 11 years so that other people also can join us. 11 years of experience in teaching MBBS, MD, MS, DM, MCA students and aspirants. I teach microbiology and biochemistry, and these are my achievements. And every single year, I have sent at least 1 or 2 students in the top 10 ranks to the central famous institutes like PGI Chandigarh, AIIMS and JIPMER. And this is about the Plus subscription for Unacademy. You can subscribe to the Unacademy sessions where you can get daily live classes, structured courses, live tests and quizzes, and unlimited accesses. And the Plus subscription may need you to have a code, and if you use the referral code either Dr. ASM or Dr. ASM YT, you can get a 10% discount and exclusive access to all my sessions. And there is something called as Iconic subscription where Unacademy has tied up with that of Prep Ladder. So you have free sessions of Unacademy which are live sessions, and plus sessions of Unacademy which are live sessions, plus that of recorded sessions of Prep Ladder. Both can come together where you can get a massive discount. Again, you can use my code Dr. ASM YT. And this is about the free live test series that are happening here. Please remember, it is free and you can have 2 targets. If you're a student who is targeting 2021, that is upcoming exam of NEET PG, every day at 8 p.m. you have the free live tests. And if you're targeting 2022 exam, then you have the live test at 9 p.m. So you can have 20 questions each every day, and you are going to become stronger by taking all these free tests. Please make the best use of them. And free live class on Unacademy tomorrow, 17th of November, at 10:30 p.m. we'll be discussing a full question paper microbiology. In a given complete question paper for a mock exam for NEET exam, we'll be discussing 30 to 35 questions in microbiology threadbare. So please be joining us. It will be on Unacademy app. 17th tomorrow, 10:30 p.m. free session microbiology, 30 to 35 questions we can be discussing. Okay, this is the code, and I'll tell you how to use this code. Please bear with me. Just one more minute. Yes, and you can download this Unacademy app, open it, and then go for Plus classes, and you can go for subscription. And you can either choose Plus subscription or Iconic subscription, and you can get the referral code. Now let's go for the first question. Let's begin the discussion here. So we are up with the discussion. Come on, people. We'll see how many of you can get me the right answer here. Now read the question here. Mr. X is a 29-year-old sexually active woman with no past medical history. She presents to your acute care clinic with a complaint of burning micturition for the past 4 days. Yesterday, she noticed that her left flank and her back were also painful, and she began having fevers up to 1 or 2 degrees Fahrenheit. She has 3 sexual partners and frequently has unprotected vaginal intercourse with them. Although she does not consider any of them high risk for sexually transmitted infection, that is, she is not considering the other partners as STD risk people. Also, her examination is notable for a temperature of 39 degrees Celsius, heart rate of 105 beats per minute, and BP of 105 by 65 millimeters of mercury, left costophrenic angle tenderness, and an otherwise benign abdominal or pelvic examination. Clean catch urinalysis shows positive leukocyte esterase test, a high WBC count, and no epithelial cells. First, Before we go into the MCQ for microbiology, let us try to make a diagnosis. Come on, people. Give me a diagnosis that you feel it is fit for the given question. Come on, Varsha, Nandini, yes. Can you please tell me the diagnosis that you feel like? Any answer would be fine. What do you think is the diagnosis? Anything is fine. Yes, very good. Come on, any other answer? Okay, Varsha thinks it is UTI. Somebody else thinks it is nephritis. Anything else? Any other answer, people? Kalibanan says Fitz-Hurkacz syndrome. Okay, then. Okay, can you elaborate, Kalaivan? Why do you think it is Fitz-Hurkacz syndrome? Because Fitz-Hurkacz syndrome is caused by two organisms. One is chlamydia, the other one can be Neisseria gonorrhoeae. So these two organisms are known for causing Fitz-Hurkacz syndrome, which is inflammatory perihepatitis. Are you seeing any signs of perihepatitis here, Kalaivanan? Are you seeing any signs of perihepatitis here, Kalaivanan? You're seeing tenderness. Now, where exactly are you focusing on tenderness? Look at this. It is left costophrenic angle tenderness. It is left costophrenic. When will you think of liver involvement if it is in the right area? Yes or no? So technically right now, liver is not the primary concern. Also think about the pelvic examination, which is otherwise normal. But what are the points that is in favor of your understanding? Look at this part. She has 3 sexual partners and she does not think of them as STD causing people, but her examination is notable for temperature of 39 degrees Celsius. Tell me, is she febrile or not? Yes, is she febrile or not? The patient is febrile, yes or no? And the heart rate is 105 beats per minute. Is it along the process or not? For the given temperature, the heart rate is 105 beats per minute. Is it acceptable? Yes or no? Is it acceptable? Yes or no? Yes, absolutely yes. So she is febrile, and because of increase in temperature, her heart rate is also increased as a reflex tachycardia for the given febrile nature. BP is 105 by 65. Is it septic shock? Is it septic shock right now? The BP is 105 by 65. Is it septic shock right now? Please understand, it is not septic shock. Only when it crosses, the DPP goes less than 40 and the SPP goes less than 80, you can think of it as a septic shock. Right now, it is not a septic condition. The patient is not actually in sepsis right now. So you present to the acute care clinic with a complaint of burning micturition, which can speak about UTI. But if it was only burning micturition, I could have stopped with UTI. But look at it, she is noting left flank and her back being very painful. So it is something called as a retroperitoneal situation. In the retroperitoneal area, which organs do you think are involved? Tell me, in the retroperitoneal zone, which organs are involved? Can you please tell me, in the retroperitoneal region, which organs are involved? The whole kidney en masse is involved. So when the kidney is involved, excellent. When the kidney itself is involved, the ureters also can be involved, the pelvis calyces can be involved. So this is actually, what is the diagnosis? Diagnosis is suspicion of pyelonephritis. You can't just say UTI. UTI is urinary tract starting from any place. It can even be urethritis. So to be very clearer, think of UTI. Which of the following organism is the most common cause of this infection? Tell me, is it E. coli, Klebsiella, Proteus, Staphylococcus aureus, and Staphylococcus saprophyticus? Among the 5, which is the best organism, the most common cause of pyelonephritis here? Come on, go for the answer, people. Okay, Nandini speaks about pancreas, understandable, but technically right now it is not pancreas because it was not palatable. Also, you understand that you were able to see the left flank being involved as suggesting of the left crossophrenic angle being involved. So it was left pyelonephritis. So tell me, which of the following organism is the most common cause of pyelonephritis in a given occasion? Okay, so Vardhan, Kalaivanan, anybody else with an answer, people? Nandini, all of you are saying E. coli. That is an excellent answer. So please remember, E. coli is the most common cause of UTI across the globe. Across the globe, across barriers, the most common cause of UTI is E. coli. Though pyelonephritis is a type of manifestations of UTI, still that is also being most commonly caused by E. coli. Now, when I say any subcondition, any sub condition, any sub condition, whatever the conditions are laid out, the number one cause of UTI will always be E. coli. So there is no doubt about it. But now let me reframe the question. If at all E. coli is the right answer for this question, in what way should I be able to twist the question in such a way I can make Staphylococcus aureus as the answer? Come on, people. In the question paper, in the case discussion, what should I do to make Staphylococcus aureus as the answer? Varsha, right now the answer is not Proteus, but let me tell you, I will come to that part. Right now the answer of this question is definitely E. coli. We are not looking for a single answer. We are looking for a combinatorial answers. So E. coli definitely is the right answer of this question. But tell me, what twist in the question can make me choose Staphylococcus aureus? What twist in the question can make me choose Staphylococcus aureus? Anybody? Anybody? Okay, let me tell you this. Remember this. In the question paper here, at no point of time have they mentioned about any kind of interaction with the GIT part. Look at this. Erase all the ink. Now, they have not spoken about prior instrumentation. Organism with increased ability. Okay, not that. Look at the clinical case history. I'm looking for the clinical case history here. When they speak about prior instrumentation, or they speak about prior catheterization, then you speak about a gram positive organism in the given culture, then the organism can be Staphylococcus aureus. Please understand, if there is any prior instrumentation kept into picture, you can bring Staphylococcus aureus into the picture. And if at all you think about the most common organism causing UTI in sexually active young female, sexually active young female, among gram-positive organism, it is Staphylococcus saprophyticus. If the people mention this pyelonephritis is because of a gram-positive organism, then you can think of Staphylococcus saprophyticus. So prior instrumentation, think of Staphylococcus aureus. If you think of sexually transmitted infection and the sexual activity is the reason for this infection, then think of saprophyticus. Let me explain how. See, all over your skin, the most common saprophyte is Staphylococcus epidermidis, which occupies 75% of the load of your skin saprophytes. Now, closely followed by Staphylococcus epidermidis is saprophyticus. The second most common saprophyte on the human skin is saprophyticus, except in the female perineum. In the female perineum, the load of epidermidis and saprophyticus is almost the same. In some conditions, saprophyticus is more common than epidermidis. Now, when a young female is having a sexual intercourse, repeated sexual intercourse, because the mechanical thrust of the sexual intercourse, you will be having this organism pushed up through the urethra, because of which you can have urethritis, and that can spread to become pyelonephritis. So, the most common cause of UTI in sexually active young female. If it is not sexually active, it is physically active, it is not Staphylococcus saprophyticus. If it is not a female, it is not Staphylococcus saprophyticus. If it is not an active female, it is not a Staphylococcus aureus. Staphylococcus saprophyticus. If it is old person, again it is not Staphylococcus saprophyticus. So the logic is young, sexually active female. And if it is among gram-positive cocci. But if I don't mention gram-positive cocci, then the most common cause of UTI, even in sexually active young females, again comes back to E. coli. This is my point of concern. So think twice before you answer. Also remember, when they speak about the pH of the urine being higher, now what organism will you think of? If I say the pH of the urine is higher, which organism will you think of? If I say pH of the urine is higher, which organism will you think of? Come on, people. Any answer? In the whole case history, they mention the pH of the urine is elevated. Which organism will you think of? Very good. Kalaivan and Nagarwin. What is the beauty here? Please understand, Proteus mirabilis is an organism known for releasing urease. That urease will break the urea into ammonia plus carbon dioxide. The carbon dioxide dissociates and becomes bicarbonate and gets lost in the urine, but ammonia will be increasing in the filtrate in the kind of the tubular secretion. So ammonia elevation can cause the pH to be elevated because ammonia is an alkaline condition. So Proteus mirabilis is what you will think of. Now let us begin with one more question. If it is Proteus, what kind of stones will not be formed? If Proteus is the cause of UTI, definitely it will be more prone for kidney stones. If it is Proteus UTI, definitely you can expect kidney stones. But which kidney stones are not common in Proteus UTI? Which kidney stones are not common in Proteus UTI is my question. Anybody? These are all MCQs that you have to know for answering INICT. They have been removed. Okay, calcium is not the right answer. I'll tell you. Uric acid stones, oxalic acid stones are not common in case of Proteus UTI. Let me tell you the mechanism. Now listen to this mechanism very carefully. This can have multiple ramifications. Now imagine if this is the glomerulus. Then you look at the filtrate. The filtrate will ultimately come here and become urine. Before the filtrate becomes urine, what are the things that can happen? You can have tubular reabsorption, you can have tubular secretion. Now, when the filtrate fluid is alkaline, when the pH is higher, you will understand one thing. Any compound who is an alkaline compound will remain non-ionic. If the compound is non-ionic, it is insoluble. But if at all any acidic compound passes through the filtrate, let me tell you once again, you are looking at the filtrate here. The filtrate fluid has become alkaline because of Proteus. Proteus is urease positive. Because of Proteus being urease positive, the whole filtrate is alkaline. And in the alkaline medium, if any kind of alkaline substance is passing through, it is insoluble. It is non-soluble, so it can be reabsorbed back into the systemic circulation. But if at all there is an acidic compound, that acidic compound becomes more soluble in alkaline pH, because of which it can be lost in the urine. So acid stones like uric acid, oxalic acid will become more soluble and can be lost in the urine. They'll not be retained back to form stones. That is why kidney stones of uric acid, oxalic acid nature is not found in case of Proteus mirabilis. This is the kind of attention that we can seek from one important MCQ that is related to the clinical case discussion. Now let us shift to another clinical case discussion. Look at the theory part here. So this is the explanation. What you saw was a case of uncomplicated cystitis and the most common acute UTI syndrome. What are the features you see in case of acute UTI syndrome? Dysuria, increased urinary frequency, suprapubic pain. And the fever or back pain will not be generally a property of low UTI. Only when there is pyelonephritis, you can have fever and back pain. That is suggestive of this. E. coli is the single most common pathogen. It causes 80 to 90% of cases, especially if it is uncomplicated. Also remember, initial cystitis can develop in 20% of women. And if at all you think about any genitourinary instrumentation, then you can think of S or S. Shall we go to the second question, people? Shall we go to the second question, people? If you have any questions, I'll try to answer your questions. Do you have any questions to ask me? If you don't have any questions, let me know. We'll go to the second question of the day. Okay, now look at this question here. 63-year-old man has been in intensive care unit for 3 weeks with slowly resolving acute respiratory distress syndrome after an episode of acute pancreatitis. He remains on mechanical ventilation through a tracheostomy. Over the last week, he has had gradual lessening of his mechanical ventilator needs. and slight improvement of his radiograph. He has been afebrile with a normal WBC for the last 10 days. Over the last 24 hours, his FiO2 has been increased from 0.6 to 0.8 to maintain adequate oxygenation. In addition, he has developed newly purulent sputum with a right lower lobe infiltrate. Fever to 101.5 degrees Celsius and a rising, 101.5 degrees Fahrenheit. I'm so sorry, this is not degrees Celsius, it is Fahrenheit. And a rising WBC. Sputum gram stain shows gram-negative plump coccobacilli. Now, can you tell me which organisms are we discussing about? Take your time. Take your time and think about an organism. You can give me any answer. Whatever organism that comes to your mind, please let me know. We are focusing on gram-negative plump coccobacilli, rounded and fat coccobacilli. So again, the patient is an old person, 63-year-old person, ICU patient. He is resolving. He has been in the ICU for 3 weeks. Now the symptoms are resolving. Acute respiratory distress is coming down, and that distress started after acute pancreatitis. For that, he remains on ventilation through tracheostomy. Over the last week, the feeding and the weaning was done. He has been afebrile with normal WBC for the last 10 days. Okay, now Garvind is saying Klebsiella. Okay, I can be taking this answer also. He has been afebrile with normal WBC for the last 10 days. So right now he is not having a systemic manifestation. Over the last 24 hours again, he has FiO2 increased from 0.6 to 0.8 to maintain adequate oxygenation. So 10 days back, he was actually becoming better. Right now, slowly he's becoming worse. In addition, he has developed newly purulent sputum. Please remember, the sputum is newly purulent with the right lobe, which is lower lobe infiltration. Okay, now Nandini speaks about Pseudomonas. If it is Pseudomonas and MTB, you don't have to worry about lower lobe. You can focus on the upper lobe itself because those organisms are highly aerobic. Remember, Pseudomonas is highly aerobic, MTB is highly aerobic, so they directly attack the superior part of your lung, that is the topmost part of your lung. The fever is right now present. So tell me, if the fever is right now present, is there an acute infection going on? Yes or no? If fever of 101.5 degrees Celsius, fever Fahrenheit is seen, is there acute infection going on? Yes or no? Okay, Kalaivanan thinks of Haemophilus influenzae. That's a wonderful answer because you saw coccobacilli, you can think of Haemophilus influenzae. Klebsiella is not a coccobacillus. So that is the reason why we will not be choosing it. Klebsiella can be a diplobacillus. I could have chosen Klebsiella for any other reason, but because there's a coccobacilli, I can't go for Klebsiella. I can give it a choice for Haemophilus influenzae also. So you all are accepting it. But the right answer is the gram-negative plump coccobacilli happen to be Acinetobacter baumannii. You don't have to worry about making a wrong diagnosis. It is not 100% easy to make the diagnosis. I am telling you the organism was Acinetobacter. Now, knowing it is Acinetobacter, all the following statements regarding infections due to Acinetobacter are true, except what is your answer? Among A, B, C, D, and E, which one is the false statement? Go for the answer, people. Among A, B, C, D, and E, which one do you think is the wrong statement? All the following regarding infections due to Acinetobacter baumannii are true except. Okay, Varsha says A. Any other answer? Only one answer. Anybody else? Come on, people, give us some answers. Okay, Varsha, okay, Kalevanan says E, Mohini says C. Okay, any other answer? Okay, so Nandini says B. Okay, let me tell you, the right answer is E. Acinetobacter baumannii is a beautiful organism. It's an emerging organism in the Americas and Australias. American continent and Australia, you are having this organism becoming more and more deadlier. And this is an important organism related to ICU infections. Before we go for this organism, let me give you some kind of factual data. Whenever we think of ICU infections, what are the organisms that come to your mind? Point number one, think of E. coli, obviously. Think of Klebsiella. Both these organisms in the ICU will be referred to as ESBL, extended spectrum beta lactamase organisms. Apart from these organisms, you have Staphylococcus aureus, Staphylococcus epidermidis, and other kinds of coagulase native staphylococci. Then you have to focus on enterococci. Apart from that, you also will focus on Pseudomonas. Now, please understand one thing. E. coli mostly attacks your GUT and GIT and then can cause sepsis, while Klebsiella and Pseudomonas are known to attack your lung. From there, it can progress to become sepsis. Staphylococcus aureus can start anywhere in any of the instrumentation. From there, it can cause sepsis. So, I repeat once again, when they speak about ICU infections, the most common organisms you think of would be E. coli, Klebsiella, Staph aureus, Staph epidermidis, Staph saprophyticus also, Enterococcus, and Pseudomonas. And when they try to tell you it is actually hospital-acquired pneumonia, the two major organisms you think of would be highly virulent Klebsiella pneumonia and that of Pseudomonas. These are the two organisms we think of when it comes to hospital-acquired pneumonia. They can also be a part of community-acquired pneumonia, but these two organisms are known to be hospital-acquired pneumonia. And if you want to be more specific, they can be acquired in the ICU, will be referred to as ventilator-associated pneumonia. The most common cause of ventilator-associated pneumonia will be Pseudomonas, closely followed by Klebsiella pneumoniae and Staphylococcus aureus. So, among all these organisms, the newly emerging organism is Acinetobacter baumannii. And so, it is a growing cause of HAP, absolutely right answer. Growing cause of sepsis, absolutely right answer. Now they are emerging as a significant problem in Asia and Australia, right answer. But you will not be able to answer C and D so easily. So mark my words, mortality from bloodstream infection approaches 40%. So what does it mean? The moment Acinetobacter enters into blood, the chances of the people dying will be 40%. Out of 100 people, 40 people will die. So what is your priority? The priority is to make sure that the Acinetobacter baumannii does not become a part of your systemic circulation. And why are we concerned about all the ICU infections? Remember, almost all the ICU infections are multi-drug resistant infections. So there is no exception for Acinetobacter. Option D is also true. But please understand, tigecycline can be used for Acinetobacter, but not the treatment of choice for bloodstream infection. Let's look at the explanation. Look at this part. Infections with Acinetobacter are growing cause of hospital-acquired infection. Absolutely fine. Acinetobacter typically infects patients receiving long-term care in the ICUs by causing ventilator-associated pneumonia, bloodstream infections, and UTI. Now, they are of particular concern. Why? Because they are multi-drug resistant, but the better answer can be they are pan-drug resistance. Nowadays, people do not know what kind of drug to be given. Previously, life-saving drug was polymyxin B and colistin. They were extremely toxic drugs. Still, they were able to buy time for you to survive. But now they are not enough to kill this Acinetobacter. So, drug resistance has become a very important activity. And healthcare worker transmission is also related to that of Acinetobacter. So, let us revise. Acinetobacter is concerned about ICU infections, ventilator-associated infections, multi-drug resistance, and also in case of healthcare worker-associated transmission. And many strains are right now resistant to carbapenems, a very costly group of drugs called as impenem meropenem. They are also failing against this particular Acinetobacter. And last line agents like colistin, polymyxin A also have been gone away. Now, tigecycline is used against this particular Acinetobacter, but once Acinetobacter enters into bloodstream, tigecycline's help on pneumonia is absolutely lesser. So remember, Acinetobacter is a growing organism, and that is the purpose of teaching this class. Please remember, Acinetobacter can have a activity whenever there is prior immunosuppressed state. Prior immunosuppressed state, or when there is any kind of prior traumatic state, or when there is any kind of prior predisposing factor. In this question, the predisposing factor we're discussing was acute pancreatitis. So when there was acute pancreatitis, acute respiratory distress happened. That distress might have been because of any kind of fluid exchange. But when the patient became better and then he became worse, it was purely because of a new emerging organism called as Acinetobacter. And how did I prove it? Because it was a gram-negative plump coccobacilli. If it was Klebsiella, it would be a diplobacilli. It was a pseudomonas, it's a complete bacilli. The coccobacilli that can cause ICU infections would be Acinetobacter. With this, we can conclude the answer is E. Tigecycline can be given as a treatment for Acinetobacter, but not when it is going for bloodstream infection. So this is why option E is wrong. So I hope you got the explanations you deserved. So if you have any other questions and clarifications, you can ask me. I'll try to give you an answer. And a small announcement, 17th, that is tomorrow at 10:30 p.m. we have a free discussion sessions for microbiology questions. Drug of choice for Acinetobacter is not decided. Right now, still people are working on tigecycline to be active, but still there is no proper drug of choice for your Acinetobacter. Tomorrow at 10:30 p.m. we have a free microbiology session. 10:30 p.m. on Unacademy app. You can follow me on Unacademy app by searching for the profile name called as Meenakshi Sundaram AS. And on Telegram, I have both group and channel. You can join me either way, either by searching for this name or I can search for this channel name. And on Instagram, you can follow me if you have any clarifications. So tomorrow, free microbiology session, that is one full question paper will be discussed. Approximately 30 to 45 questions in a mock test question paper can be discussed. So please join me live on Unacademy app on 17th, that is tomorrow at 10:30 p.m. So till then, thank you very much for joining us. There is one more class. There is a YouTube session tomorrow, and that YouTube session, I'll let you know about it on the Telegram channel. That is what I'm saying. There is no proper drug of choice. You can go for multi-drug treatment in case of Acinetobacter pulmonale. So polymyxin B, see, instead of polymyxin B, I can go for polymyxin A. So polymyxin A can be given, and that is actually colistin, that can be given as a treatment option. So though it is a failure for polymyxin B, polymyxin A can still be tried. And apart from that, combinatorial drugs like aminoglycosides will be effective. So synergy is what we are depending on. Okay. So if there are no other questions, and if you would like to subscribe for the plus classes, use the code Dr. ASM or Dr. ASM YT. So thank you very much. Have a good night.